Good morning. Thank you all. Thank you all for being here today. My name is Lisa Warren. I am an occupational therapist by training, but I am the rehab manager at the Fixel Institute. So I oversee our rehabilitation department, which consists of occupational therapists, physical therapists, and speech-language pathologists. So I'm going to talk to you this morning about the importance of getting tied in with our department or a rehabilitation group as soon as possible. So we're going to go through, and I'm going to explain what each of these disciplines do for Parkinson's. Okay? All righty. Has anyone been to the Fixel Institute? All right, and keep your hands up if you've seen our rehab department. Okay, good. All right. So, as I said, we're going to talk about what is OTPT and speech. That SLP is speech-language pathology. What can you expect when you see us? Will your insurance cover it? That's a big question, so we'll talk about that. And how do you get therapy if you don't live in Gainesville? How many of you do not live in Gainesville? Yeah, that's what I figured. I will tell you that about 80% of the patients that come to the Fixel Institute do not live in the Gainesville area. They live more than an hour away. We have folks throughout the state of Florida, from all over the country, and we have international patients that come in. So I'll tell you how, if you don't live here, how are you going to get therapy when you go back home? So we'll talk about that a little bit as well. So occupational therapy, to start with this one. Sometimes people think occupational therapy means they're going to find you a job, and nobody wants that. If you're retired, nobody wants that. Nobody's interested in that. I want you to think about it as what occupies your time, and so that can be anything. It can be sleep, it can be brushing your teeth, it can be work, it can be driving, it can be writing, it can be anything that occupies your time is what the occupational therapist is going to be looking at. We're interested in keeping you independent in those tasks and having a good quality of life. So our goal is to find the way for you to continue to do those things. We may have to adjust it a little bit. We may make suggestions on different ways to do it, but the goal is to keep you doing it. So these are just some, we call them ADLs, which is activities of daily living, and it's whatever you do in a 24-hour period. So all of these and then some. Anything you're doing during your day is what we are going to be interested in. And I'll tell you in a minute when we get to physical therapy how that differs from what physical therapists are looking at. So how does Parkinson's interfere with your day-to-day life? So most of you could answer this pretty quickly. Muscle rigidity, which impacts your posture, your ease of movement, the speed of movement, and your comfort in moving. Big problem. I honestly think that rigidity, that muscle stiffness, is one of the most disabling features of Parkinson's, and we'll talk a little bit about that in just a minute. Tremor. Your tremor may interfere with function, or it may just be irritating. A just typical Parkinson's tremor is called a rest tremor. And so that means it's worse when you're not doing anything. When you're just trying to sit there and relax and be comfortable, then that's when that tremor creeps in. When you activate your muscles, so when you reach out for something, when you do something, it should dampen the tremor. Now, if you go and you pick up a glass of wine, a bottle of water, whatever it is, and then you stop and you hold it, then it's going to creep back in, right? But that movement to reach out and grab it should dampen the tremors. So most of the time, they don't necessarily interfere as much as they're just irritating and sometimes socially embarrassing. Sometimes people don't like tremoring in public because people think, well, what's wrong, or what are you nervous about, or what are you up to, or you're not telling me the truth because you're tremoring. So it's more irritating, more embarrassing than usually functionally impairing. Now, that is not 100% true. There are people with Parkinson's who have a little bit of what we call action tremor. So they may tremor at rest, but when they activate the muscles, it may not fully suppress the tremor, and they may have a little tremor with movement. So it can interfere with function, just not as common. Balance changes. So If you have Parkinson's, your balance is going to change. We hope that that's way, way, way down the road. Our goal is to push that off as long as possible. But the little balance center in your brain will change. It also changes as we age, right? I mean, that just happens. That's just a part of life. I had a really bad fall a little less than a year ago, and I don't have Parkinson's. So it happens as we age, it happens, period. But it does affect your balance center. Your reactions can be a little bit delayed, so you don't catch yourself quite as quickly. So balance is something that we concern ourselves with, and then we are concerned about how you're doing your daily task if your balance is a little bit off. And then mood changes. So Parkinson's isn't always just a movement disorder. It can be a mood disorder. I mean, your life's changed, right? With this diagnosis, your life's changed, and so did your partner's or your family's lives. Everybody's involved in this. And so we can see depression in Parkinson's, isn't unusual. Anxiety in Parkinson's. We can see apathy. And of those three, apathy is one of the more challenging. Apathy is just that loss of motivation to do things, even things that you like. It's just a struggle to get up and go do things that were typically fun or used to be fun for you or enjoyable. And there's a lot of research that shows that your activity level is of utmost importance. So you will hear research after research after research on exercise, and boy, is it important. It's important for all of us. Every single one of us should be exercising. But that isn't all you should do. You also have to live life, right? You can't go exercise and then lay on the couch for the rest of the day. It's going to negate any benefit you got. You need to exercise, and then you need to live life. And that means whatever that means for people your age, whatever that is. Going to grandkids' events, going and having coffee with the guys, having drinks with the girls, whatever it is, you need to stay engaged in life. All of those things are what slow the progression of Parkinson's. So many of you are probably on some form of carbidopa-levodopa, and I've heard it called all sorts of names. But the best thing it does is help you function. And so you take your medication and then you live life, because that living life, engaged in life, is what actually slows the progression. The medication is to help you do that. Okay? So those mood changes are really challenging because they make us want to sit back and not do as much. So one way to address that is develop a routine for activity participation, a weekly schedule. So if you're suffering or if your loved one is having difficulty with apathy, you used to go have coffee with the guys or used to go golf with the guys at 10 o'clock every Tuesday morning, then you need to make that a scheduled activity. That's the best way to fight apathy. It is just what you do at a particular time, and it's just as important as medication, because it really is. It's just as important as your physician appointment, because it really is. So 10 o'clock golfing with the guys, 10 o'clock coffee with the girls, whatever it is. If you're struggling with apathy, or if your loved one is struggling with apathy, now you have to schedule that task, and it is just what is it. No is not an option, unless you're on your deathbed. And I mean in the hospital on your deathbed. No is not an option. You have to go. And so often, like most of us, once you get there, you're like, oh, I'm glad I did this. But it's just getting there that is the challenge, okay? So force yourself to do it. There's so much benefit in being engaged in life. If you sit home and you're watching TV, there's no interaction. You know, nobody's asking you anything. You're not really having to move. You're not having to think. But if you go out, even if you just go to a restaurant, you know, the waitress what do you want to drink? What do you want to eat? How do you want it cooked? There's stuff to think about. There's interactions, and those are so good for us. These are the things that occupy our time that we want to keep you doing. Okay, so whatever it is that you enjoy doing, we got to keep doing it. Stay engaged and involved in life with others around. Discuss strategies for managing fatigue is something, stress, anxiety, sleep, visual changes. These are all things that the occupational therapist is going to cover with you. Managing fatigue, I'll touch on that for just a quick second. Boy, there is just inherent fatigue that comes with Parkinson's. You just feel tired. Parkinson's can affect your sleep. If you're not sleeping well, then you can't be, full of energy the next day. You don't think as clearly. All of us, if we don't sleep well, if we don't get good restorative sleep, after a few nights that adds up, we can't function as well. So Parkinson's is no exception. That's a big problem. So we will work with you on sleep, what's called sleep hygiene, making sure we're doing everything right to get you good restorative sleep at night. And so hopefully that helps manage some of that fatigue during the day. If you think about just your muscle tightness, when muscles are tight, that what we call rigidity, it takes more effort to move a tight muscle than it does a relaxed muscle. So now every movement throughout the day just takes a little more effort, right? So you're expending more energy than you used to. If you're tremulous, you're expending some energy because your muscles are constantly activated when you're tremoring. It's exhausting. It's exhausting. If you have to think about your balance, how you're walking or how you're moving or backing up to a chair, it's tiring. You've now added more to that cognitive load just to move throughout the day. So if you feel tired after lunch, there's no shame in napping. Put your feet up, relax for a little bit. Hopefully it gets you through that afternoon. But when you see the occupational therapist, that is something he or she should go through with you. What is giving you difficulty during the day? What do you want to be able to do that's difficult? And then trying to go backwards from that and figure out what is interfering with that. The occupational therapist is going to teach some adaptive techniques and strategies so that you can perform whatever it is, do whatever it is that you want to do during the day. We call it adaptation or compensation. We give you some compensatory strategies, or we adapt whatever you're doing so that you can stay independent and safe. Safety first. We're going to discuss with you the medication, particularly the carbidopa-levodopa, and your activity. So I mentioned earlier that carbidopa-levodopa, many of you are taking Sinemet as a form. Some of you may be on Rytari, another form of it. It helps you function. The best thing it does is it reduces that muscle stiffness. It can help with tremor. Doesn't always, but it can help with tremor. But it helps you move. Okay, so we're going to talk with you about when you're taking it and what activities you're doing at what point in that medication cycle. There's a little bit of ramp up, and then that medication starts wearing off, and then you're going to take the other one. So if there's something you're struggling with, we're going to look at where you are in your medication when you tend to do this particular activity. We may suggest some adaptive equipment to make things a little bit easier. I'm just going to go through these quickly. We got a late start. So anybody know what this is called? He put his sock on it, and he's going to pull it up his leg. It's going to put his sock on. Any guesses? Sock aid. Yeah, gave that one away. This is actually a really neat device. If you're having trouble reaching down, if you've had any type of hip surgeries, replacements, anything like that, and you're a bit limited in your hip range, it's a fantastic device. Any occupational therapist that you see should have one for demonstration so that you can try this out. So as I said, you put it in your lap, you slip the sock on, you drop it on the floor. He's got the handles there, and when he pulls that up, it's going to pull the sock up on his calf, all the way up to his calf. So super great device if that's difficult for you. Any ideas what this is? It's a button hook. If you're having trouble because of tremors, this may not be all that helpful. But if you feel like your coordination, the rigidity, things are just labor intensive for buttoning, this has a little hook. It goes through the hole. You hook it around that button, and then when you pull it back, it pulls the button through the hole. So great little device to help you button your shirt. So that's a button hook. There are shirts that have magnetic closures. They look just like a button-up shirt. The buttons are sewn on the outside, but it's actually magnetic. So there's a lot of little tricks that we can help you with so that you can do the things that are important in life, like going to the grandkids event and not spending 30 minutes trying to button your shirt. We want to get you doing the things in life that are important. This one, not many people use this. I tell you what I use it. It's called a dressing stick, and it has a hook on one end, and it has this little zigzag on the bottom that she's using there. It's great for grabbing things on the floor, not grabbing them, but hooking things on the floor. Again, if bending is difficult or if your balance is poor. I like this for digging things out of the washing machine, the drum of the washing machine. So if bending is difficult or you can't reach the clothes in the bottom of the machine, we all still have to do laundry, right? Unless you have somebody doing it for you. This is a great little device for reaching down. A cane can help you with that too. The bent end of the cane can reach down and help you get clothes. And out of the back of the dryer. If bending over and you can't get those clothes out of the back of the dryer, little devices like this can be super helpful in doing that. So that's a dressing stick. All of these are things that your occupational therapist should have on hand to show you if it's appropriate for you. This one, I would take any of those answers except for mop. I hear it called a picker-upper more than anything. It's actually a reacher, but everybody has seen these. Good for getting things off the floor. It has the little clamp at the bottom. You can also use it to get clothes out of the dryer or things out of the washer. They have some really heavy-duty ones like at Home Depot or Lowe's that the long guys will use picking up stuff off the ground. Those are good for getting a box of cereal or something up high that you may have difficulty reaching. So those are called reachers. So those can be really helpful too. I'm going to skip these last two so we can get to a couple of the other things. I don't want to spend all the time on this. So just know that your occupational therapist is going to have a lot of ideas of things to help you stay independent. And it's not always using devices. It may be body mechanics. We may just show you a different way. It may be stretching. It may be a variety of things. So we're going to do that analysis with you and then figure out what works best for you. You know, whenever you go to therapy, whether you're with us or you're somewhere else, one of their questions to you should be, what's bothering you the most? And that needs to be addressed, okay? It should not be their agenda, what they think you need. They need to be addressing what bothers you the most. Every single one of us in here are different. And what we want to do or what we have trouble doing is different. You will hear 100 times, if you've seen one person with Parkinson's, you've seen one person with Parkinson's. Everyone is different. So you make sure, whether it's OT, PT, or your speech therapist, you make sure they're addressing what you want addressed, what's bothering you the most, whether you're outpatient clinic or home health. These should be your goals, not theirs. Okay? All right. So, message from OT, take your medication on time. However, the neurologist has prescribed it. 3 times a day does not usually mean every 8 hours. It's 3 times a day when you're doing stuff, right? It helps you function. So usually it's breakfast, lunch, and dinner. Typically they may give you a schedule to stay on, but that duration is what's important. If they say 3 times a day, they're calculating about every 5 to 6 hours, okay? Not every 8 hours. There are reasons people need it at night, but mostly it helps you move. Take it when you get up, middle of the day, late evening if you're on 3 times a day. Now, sometimes that window closes. Some of you may be taking it more frequently. Rytari can go up to, I think, 4 times a day is about the max. So you may be taking that every 4 hours, something like that. But take it while you're awake because it's to help you function, okay? And stay mentally and physically engaged in life. Even if you have to do it differently, that's okay. But let's find a way to keep you doing what's important to you. Physical therapy, everybody's far more familiar with physical therapy than the other 2 therapies, but this may not be the type of physical therapy that you've had. You may have had physical therapy for an orthopedic issue, okay? That is not what we do. Our physical therapists are neurology specialists, and so they are going to do neurophysical therapy with you. The evaluation is going to be based on neurological issues, not orthopedic issues. So very, very different. There's an orthopedic physical therapist on just about every corner. Many of them go into physical therapy to do orthopedics. Ours are neuro-based physical therapists. So they're going to look at what's bothering you. They're going to talk to you about exercise, balance, overall conditioning. That is their interest, is that you're walking, you're moving safely, and then that exercise, that overall conditioning. So they want to restore, if possible, function or find you a way to function safely. doing those things. So exercise, conditioning, training, education. They can also use compensatory techniques, adaptive equipment. Some of you have walkers. You may have a cane, whatever it takes to get you living life safely and keeping you mobile and doing the things that you want to do. So they're going to look at all of those things. How does Parkinson's interfere? Well, that muscle rigidity that I talked about, that muscle stiffness is what that is. It causes difficulty. You don't move easily. Like I said, it takes more effort to move those tight muscles. There can be discomfort. We just accept that there is Parkinson's related pain. And if your low back muscles are tight, that's painful. That's uncomfortable. So we know there's pain with it. So they'll show you some stretches that can help and talk to you about medication, when you're taking your medication and when you're doing your exercise or doing these activities. Your walking is going to change. It is likely to change. And so they're going to, the first time in the clinic, they're going to do an evaluation of your walking. And then every time you come in, they're going to be looking at that because we want to know when it changes and how it changes. Balance reactions may also change. And so that's something else they're going to be on top of. Mood changes. So here we go again. So this definitely interferes with your activity participation and your exercise participation. So if you're going to Kelly's exercise class over here, what time is it, Kelly?
10:30 to 12 on Tuesdays and Thursdays.
Okay, so if you're going to the Senior Recreation Center here in Alachua County to exercise with Kelly at 10:30 on Tuesdays, and you're struggling with that, then this is an appointment. This is an appointment that can't be missed. This is as important as the medication, the doctor's appointment. This is an appointment. So with apathy, if you're struggling with apathy, that decreased motivation, this becomes an appointment on your calendar that is really important that you go to. Something that's really interesting is that with Parkinson's, your world kind of becomes softer and smaller, and things come inward. Your force of movement also gets affected, and what we mean by that is that the amount of effort you put into something can be a little bit skewed, or you put in the same amount of effort that you used to, but you don't get the same results that you used to, so it takes more. And so the physical therapists and the occupational therapists too are going to be looking at that and talk to you about that. And where that becomes challenging is getting in and out of the chair, on and off a toilet, just not putting forth as much effort as it requires, but as you're putting forth what you think, and you're just not getting the results that you were hoping to get from that. Decreased participation in exercise or activity, more immobility can lead to weakness. So this is a really important take-home point here. If you don't take home anything else today, I want you to know that Parkinson's does not make you weak. It does not cause muscle weakness. It causes muscle stiffness, and it takes more effort to move a tight muscle. It can cause fatigue, so you don't last as long doing things. You put more effort into it, you wear out quicker. But when you are tested against folks your age without Parkinson's, those muscles, rarely are they weaker unless you've stopped doing things, right? The less you do, then you're going to get weak, just like me. That will happen to me too. The less I do, the weaker I'm going to get. So the diagnosis, the disease itself does not make you weak unless it has made you inactive. Through balance issues, you don't want to go anywhere, mood changes, you don't want to go anywhere, whatever it is, you stop doing stuff, then you're going to get weak. And then once that happens, if you do fall, the recovery's harder, the weaker we are. So we want to stay strong, we want to keep engaged in life and prevent all of that, keep our strength. Now there's as we age, we do get weaker as we age. So I'm not talking about age-related changes. And that's so hard with Parkinson's, right? Typically it happens in our 6th decade of life. It can happen before, it can happen later. But we're also experiencing age-related changes. And so often people will say, well, is that my age or is that Parkinson's? And usually the answer is yes. it's a little both. Darned if you do, darned if you don't, but that's just how it happens. So the physical therapist intervention, they're going to be working on fall prevention, gait training, meaning walking training. Sometimes it's visual cues, tactile cues, which is touching, or verbal cues, whatever it takes to help you keep moving. There's something called freezing of gait, if you all have heard of that, and that's where you just sort of stop. The feet stop moving. Usually happens in a small space, in a doorway, in a crowd. They're going to analyze that, figure out what gets you through that to try to prevent it. Because a lot of falls happen. You can imagine if you've got the momentum going this way and then your feet stop, you're still headed that way, or the momentum is still going that way. So a lot of falls happen from freezing of gait. So it's certainly something they're going to address, figure out how to prevent it as much as possible. And if you do get stuck, how to get you out of that. Wellness promotion, that has to do with the exercise, the conditioning, all of the above. Improve your mobility in and out of a chair, on and off a toilet, in and out of the car, moving from point A to point B. Enhance cardiovascular fitness. Posture re-education. This is super important. The occupational therapists are going to do a lot of this. And that is that muscle stiffness brings you here, brings you down this way, whether you're sitting or standing. So working on stretching and that postural re-education is something actually both disciplines are going to be addressing. Improving your quality of life. Think big. There's a Big and Loud program some of you may have been involved in. There's another one called Power. All the strategies are fantastic. I said Parkinson's brings you in this way. Those programs take you out. Louder, bigger movements, and then honestly, they just come across as normal when you try to exaggerate. And then the physical therapist is going to work with you on multitask training. Rarely do any of us do one thing at a time. But doing multiple things at a time with Parkinson's can be a bit more challenging because you're having to use some of that cognitive load on how you're moving, on your balance, on your stepping, watching what you're doing. And then you're trying to carry on a conversation or figure out what's going on over here. It just becomes a lot. But that's what the physical therapist is going to work with you on if multitasking while you're walking is becoming a little more challenging. Some exercise ideas. The best exercise. Anybody know what the best exercise is?
The one you'll do.
Well, the one you'll do. Yes. Have you been to one of my lectures before? Oh, good. Oh, perfect. Yes. The one exercise that's the best for you is the one you will do. These are the Parkinson's Foundation came out with exercise recommendations. You can do anything that you want to do that is safe. You can do it. So every few years, something comes out that is the new sexy thing in Parkinson's that you have to do if you have Parkinson's. It's been Tai Chi. Fabulous. It's fantastic for you. Tai Chi is great for balance. It's great for getting centered. It's great for body control. So for a while it was Tai Chi. Then it was cycling. Cycling's fantastic. It's great aerobic activity, so it's wonderful. Now boxing. For the last several years, boxing has been the hot thing. Fantastic. It works on balance. It's aerobic. They do a lot of stretching. It doesn't matter. You just need to move. You need to exercise. And if you think about exercise in three components, mostly strength training, resistance, whether it's with weights or bands or machines, there's a lot of ways to do resistance training, strength training. Every single one of us in this room need to do that. But you don't need it more than I do, right? Because Parkinson's isn't making you weak. It's just important for all of us to do strength training. It's good for bone health too. So we all need to do some resistance training. So that's one type. If you think about aerobic is something you can do continuous, let's say 20, 30 minutes, get your heart rate up, get your respiratory rate up. It can be on a bike, it can be boxing, it can be on a treadmill, it can be swimming, it can be dancing, it can, whatever you like to do. That's important. That's how we build stamina. Aerobic activities help us fight fatigue. So that is important for you because there is fatigue with Parkinson's. So make sure you have an aerobic component. And then if the third component, stretching, flexibility, probably the least exciting for most people, but actually one of the most important because of the muscle stiffness that comes with Parkinson's. So I don't care if you do yoga or you just have some stretches you like to do. Doesn't matter. But stretching is an important component. It isn't going to keep you from getting stiff from the Parkinson's, but what it will do when muscles sit tight, if you never fully elongate them, they will shorten. And if our postural muscles shorten here, well, that's just as good as it gets, or whatever muscle group we're talking about. So stretching, very important to prevent that shortening, that long-term shortening. And then the Parkinson's Foundation added a fourth one on balance. So absolutely important. And a lot of those activities I just mentioned, you can also work on your balance the same time you're doing those activities. So we all need those three major types of exercise in our lives, okay? But the aerobics is going to help you with fatigue, and the stretching is going to help you with keeping the length of your muscles. And then every single one of us need that strength training. So I saw you guys out dancing, doing some dancing in there. So you've already done some boogieing. I'm going to show you just a couple of brief exercises. Everybody put your feet flat on the floor for me. This is a great postural stretch if you're kind of snug in here. Try not to hit your neighbor. But put your hands behind your head if you can. And then what I want you to do, and I've got a recovering from a shoulder fracture from that fall I told you I took. So I don't have great range yet. Take your elbows back as far as you can behind you, and then I want you to look up. Hold that and breathe. This is a fantastic postural stretch. You're stretching the muscles between your ribs right now. You're opening your chest by getting those elbows back and stretching your neck muscles. You can relax. If you're on the computer during the day working or playing games, we're in this position. Ever so often, get in that position and let's elongate. Let's elongate that trunk. Stretch out of this, okay? And then right now, just if you can grab the back of your chair and turn, you don't have to cross your legs like she did, but just turn and look behind you. This is great trunk rotation. Either side. So this is a good one to do during the day too. Parkinson's makes us stiff and we move like a board, right? And we lose some of that rotation. So keeping those muscles stretched out so that you can rotate, super important. Take home message, medication on time. Everybody wants you to take your medication on time. Exercise regularly to delay the disease. Let's jump into speech really quickly. Speech therapy. They're going to look at treatment. They're going to do assessment and treatment of speech, swallow, and cognition. So there are several groups at our institute that will look at your thinking skills. We have neuropsychologists who do a full battery of cognitive assessments. Occupational therapists can do cognitive assessments and training, and so can speech language pathologists. So a lot of us are going to be looking at how you're thinking. They're going to listen to you talk. They're going to watch you swallow stuff under x-ray, and they're going to check your thinking skills. Your voice can be too soft. Those of you with Parkinson's, has everybody gotten hard of hearing that's around you? Everybody's saying, huh? What? So everything gets softer and smaller. So she's got on here, walk big, speak loud. So you really have to work to project. You're going to feel like you're yelling, but it's going to come across probably pretty normal to us. You can run out of air. I'm guilty of that. You keep talking and you forget to breathe. And then you've gotten, before you've gotten to the end of your sentence, you're out of breath. Your rate can be too fast or it can be too slow. And so they're going to address that and keep you so that you can talk with your family, friends, whoever it is that you want to communicate with. You can have trouble chewing. You can have a delayed start in your swallow. You can have some coughing or some choking, or you can feel like food or pills are getting stuck. You can also have things go into your lungs and not cough, not feel it. So we can have a depressed sense of that reflex that we typically have. Everybody's gotten stuff down the wrong pipe and you've coughed your head off until hopefully you got it up. Often in Parkinson's, that's just a bit diminished, and little things can go down the wrong pipe into our lungs. and we don't know it. And so over time that becomes dangerous, right? That's when we get aspiration pneumonia. So these speech language pathologists are fantastic at looking at this. So here is, if you come to us and we sign you up for a swallow study, which is something we want to do about every year and a half, every 2 years, to make sure things are going where they are supposed to go. So this is someone taking different food and textures, and so you can see as it goes down. So they're watching, where does it go? And in the one before, there was a little bit left over right in here, right up at the, right up there. And so this is a solid. So this is what they're looking at, and they're analyzing, did it go back before this person swallowed? Did it go in the back of the throat before they actually initiated the swallow? Did some of it, was there residual here that once they start to breathe, now the air pipe is open, and then this is going down in there. So this is something they're going to look at. It only takes about 25, maybe 30 minutes max. You'll have different textures from thin liquid to an animal cracker. All of it has barium in it. That's the downside to it. That's what makes it show up on x-ray. But we'll want to watch this because there's a good chance you will have swallowing changes. Doesn't mean you're going to choke. Doesn't mean you're going to have aspiration pneumonia. We want to prevent it. We want to make sure that if this changes, we know it and we're on it. Okay, so that'll be something we want to sign you up for pretty early on. So your thought process can be a little bit slower. You can be a little slow to respond. People may think you may not have heard them or you're not paying attention, but it's really just, processing everything can become a little bit slower than it used to be. Slower to respond, difficulty multitasking, there's that again. And often happens when we have age-related changes, right? All of us have that time where we can't think of the word. It's on the tip of your tongue. It's happened all our lives, right? And isn't this a fun game? So this is one of my favorites for that. So if you're having word finding difficulty, more than usual, every single one of us have had that, where that word's on the tip of our tongue. And I'll tell you, the more tired you are, the less sleep you get, the more stressed you are, the harder this is, the more difficulty you'll have with word finding. This game called Heads Up is a board game, but it's also on many of our phones. It's I know it's on iPhone for free. I'm not sure about the Android, but it's like that. I think they brought the game back. Do you all remember Password?
Yeah.
So it's similar. Yeah, it's similar to that. There's a category, and one of you, both of you know the category. One of you is going to know the word in that category. So like this, I just gave you the categories, animals. So the person giving the clues may say black and white, stripes, shaped like a horse, and then the person guessing it then of course comes up with zebra. But it's actually good for both of us because I've got to come up with the words to describe in a period of time, and you got to come up with the word that I am describing. So it's actually good for everybody playing. It's good. Makes us pull out that file in our brain and find that word that's there. So let me give you one. Categories: movies. Movies is the category, okay? I'm going to just shout out when you think you know what it is. Set in the South. There you go. Yeah, so now you get it. You see how that is. Referrals to therapy. It is never too early to see the OT, PT, and speech. We prefer to see the day you're diagnosed, okay? Because we want to provide education. We want baseline. This is how you're doing today. That way, when something changes, we can recognize it, okay? Because things change slightly over a long period of time. But if we are evaluating, collecting numbers, we see it, pretty quickly when it changes. So we want to see the day you get diagnosed. And it's never too late. It's never too late to see us either. So often outside, our physicians are really good, but others sometimes won't refer to therapy until there's a problem, right? Well, maybe I could have delayed that. Maybe we could have had another year before that happened if I had seen you sooner. Never too late. We'll start where we are, and we'll try to make things better moving forward. But as soon as you can, get these evaluations, and let's get baseline information. Let's get some education. The therapists are going to tell you, this is why you're experiencing what you are, and this is what we're going to do about it, and this is what I want you to look for, and this is how we're going to prevent it or slow it down, okay? And every session should be like that. So let me go back to that for just a second. I talked about, well, most of you are not from here. So if you come and see us, which I hope you do, if you're seeing our neurologist, OTPT and speech are going to evaluate you, and then if we feel like you need continued therapy, we're going to get you set up at home where you live. Okay. We keep a database of clinics that have neurotherapists throughout Florida and much of Georgia. Those folks that are out of state, we're going to find it there also. We're going to go onto the internet and look at a database of therapists and try to find a location that has neurotherapists. Most of them reside at a hospital-based clinic. They're usually associated with hospitals more so than a freestanding clinic. But we are going to evaluate you. We're going to write up a plan of care. This is our area of expertise. This is pretty much all we do. We don't see patients with strokes. We don't see spinal cord injuries. We don't see all of the other neuro things. So we're doing about 600 visits per month just in our therapy department. So we got this. We know what you're dealing with. And if we don't, we're in the same building with the neurologists, So if it's something that we haven't seen or don't have an answer for, we have them sitting right next to us that we can ask, their advice on. So we want to see you. We'll set you up at home. You don't have to worry about driving back and forth to Gainesville for therapy. We'll get you set up at home, but then we want to see you when you come back to see the neurologist. We'd like to see you at least twice a year. And that allows us to track those changes and get things started. Sometimes we may just tell you, hey, go home, work on this. These are the stretches I want you doing. Continue this, stop that, add this. We'll see you in 6 months. And then sometimes it's, we got to get this. We need to attack this right now, and so we may get you set up with a therapist at home. We offer to co-manage and communicate with them. We're going to send our evaluation. We're going to send a list of, if you lived here, this is what we would be doing. We're going to send that to them and then make ourselves available to help them, because chances are they see a lot more than just Parkinson's. They're neurotherapists, but they're also seeing strokes and spinal cord injuries and head injuries and a lot of other things. So we want them to reach out to us if they have questions. Okay, one last thing, and then we got to get you to your next session, is I want to talk about, everybody has, or not everybody, a lot of people have questions about who pays for this. If you have, the best way to explain it is if you have private insurance, you're going to have to check with Blue Cross Blue Shield, Aetna, whatever your policy, Humana, whatever your policy is. They often will limit either number of visits, or they may give us a number of visits in a certain time frame. You have 3 months, and I'm just going to throw something out, 12 visits. And so if we want more than that, then when we get to the end, we have to request it, may or may not get it. Those are private insurances. Most people are on Medicare or a Medicare replacement, Medicare Advantage policy. Straight Medicare, there is a cap of $2,330 for PT and speech combined. That is a calendar year, January to December. Occupational therapy has a separate cap of $2,330 for just OT. It is a soft cap. If you're coming to see us, you don't even need to listen to this because we understand this. But if you're getting therapy elsewhere, those are soft caps. They are not hard caps, meaning the therapist can go beyond that. Okay, but they have to justify it in their documentation, and Medicare's made it really simple for them to justify it. These are progressive diagnoses that we don't have a cure for, and Medicare has finally recognized that you're not going to look like you did when you were 20. We're not trying to get you back to 10, 20 years ago, okay? That this is progressive. So they allow us to do what we call maintenance therapy, which is just always seeing you without a discharge. We can't see you frequently, and you don't need it. You do not need 2 to 3 times a week, 4 to 6 weeks. If it were an acute injury and recovery, that's exactly what you would need. You need that for a stroke. You need that for an ankle injury. But you don't need it for Parkinson's. It doesn't change that quickly. You need someone looking at you throughout the duration. Okay, so we don't ever discharge our folks here. We don't see them that frequently, but we don't ever discharge. We might start you out twice a month and then back down to once a month. You're really doing well. Maybe we see you once every 3 months, but we don't do 2 to 3 times a week for 4 to 6 weeks. That is an acute dosing of therapy. That is not what you're dealing with. So make sure they spread it out. They can. Medicare allows it. Medicare pays for it. That's outpatient. Home health is a bit different. Home health has to jump through a few more hoops than outpatient does. Okay, so if you're on a replacement policy, Medicare Advantage, though some of them follow standard Medicare, some of them are more like their Blue Cross Blue Shield private policy. So it really just depends on what policy you're on. Straight Medicare pays 80% of therapy. If you have a secondary insurance, they'll pick up the 20%. So you should, if you have two insurances, a supplemental, you shouldn't be out of pocket for any of that. Okay, we're done. Yep. Thank you all so much. Thank you. I hope to see you all in the clinic.